So I've started the call to be recorded, and so this is Jen Nagy with the American Cancer Society, and I am actually here with another partner of mine, a health systems partner, and a primary care partner, and we're here to talk to you about colorectal cancer. The staff that are a part of this group presentation is Dave Egley, Mike McGeesey, and myself, and we did a presentation in the middle of May, and we're ending with this presentation for the community, for volunteers, for staff, for board members, anyone who wanted information on colorectal cancer. And so this is the second and final presentation. If you don't know who we are, this is a picture of Dave, Mike, and myself. So just so you know who we are, that's who's speaking tonight. And we're going to get right into the presentation. And I'm going to pass it over to Dave.
All right, thanks, Jen. As Jen said, my name is Dave Egley, and I'm with your American Cancer Society. I work in the primary care field. I work with what are called federally qualified health centers. These are the health centers that receive federal dollars. They work with folks that do not have insurance. Also, a lot of folks with Medicaid. My territory runs from Muskegon over to Saginaw and all the way up to the tip of the Keweenaw. And there's folks like me all across our region doing the kind of work that we do. Our learning objectives for tonight, we're going to define colorectal cancer. We're going to discuss some of the causes and risk factors, look at colorectal cancer screening methods and your American Cancer Society guidelines, some screening best practices, and then we'll wrap up talking about our 80% in every community initiative. Next slide, please, Jen. So what is colon cancer? Well, the colon is the large bowel or the large intestine. It's a muscular tube that's about 5 foot long, obviously part of your digestive system, and its function is to absorb water and salt from food, and it stores waste matter. The rectum is the last 6 inches of the digestive system. Next. So colorectal cancer is, cancer in general is the growth of abnormal cells. These cells can invade and damage normal tissue. Colorectal cancer starts in the colon or the rectum. And you're going to hear us talk about we're either going to say colorectal cancer or CRC. Same thing. CRC is just an abbreviation for colorectal. Next slide. So what does colorectal cancer look like? If you look at the picture on the far left, that's a normal colon as seen through the scope during a colonoscopy. The middle picture is a polyp, an adenoma, and these can develop into colorectal cancer, which is the far picture on the right. We know that if you remove these polyps, your chances of getting colorectal cancer are significantly reduced or eliminated. Next. So what causes colorectal cancer? Unfortunately, we don't know the cause of most cancers. The most likely cause are related to changes in our genetic material, our DNA and our cells. And most DNA changes are related to our lifestyle. Next. When we look at risk factors, those are anything that can increase or decrease a person's chance of getting a disease such as cancer. With colorectal cancer, most of it occurs in people the ages of 50 and older, but we recently reduced our age that we recommend for screening, and Mike's going to talk about that in a minute. But we did that because we're starting to see more and more colorectal cancers in people of younger age. Big risk factor is your diet. If you have a diet that's high in red meats like pork, beef, or lamb, or processed food, hot dogs, bacon, cold cuts, beef jerky, all of that. Those all raise your risk of contracting CRC. Contrasting with that, if you have a diet that's high in fruit and vegetables, you can lower your risk of contracting colorectal cancer. Next. Physical activity. If you're less active, your risk raises. If you're overweight, if you're obese, your risk of having CRC increases. So you kind of look at, there's a trend here. Poor diet, lack of activity, overweight, all those things increase your risk of developing colorectal cancer. Other behaviors that we do, such as smoking, heavy alcohol use, increase your risk, as does having type 2 diabetes. Next. So how common is colorectal cancer? Well, it's the third most common cancer in both men and women in the United States. and it's the second leading cause of cancer-related deaths in the U.S. when men and women are combined. This last point, though, is really the kind of the gist of what we are talking about tonight. And that is that it's estimated that more than half of all cases could be prevented by regular screenings. So that's either a colonoscopy or a stool test. Next. So when we look at the incidence rate of colorectal cancer, nationwide here in 2019, it's estimated that there's going to be over 145,000 new cases of CRC and over 51,000 deaths from colorectal cancer. Here in Michigan, estimated new cases are over 5,000 this year, with over 1,600 people dying from colorectal cancer. And that's second only behind lung cancer. Next. As I mentioned, a big part of preventing colorectal cancer is getting screened. Unfortunately, that we're finding that there are significant disparities across populations on who is being screened. Unfortunately, this data is a little bit old, but it certainly demonstrates the point that when you look at the total graph on the left, you can see that dating back to the year 2000, only 39% of eligible adults were being screened for colorectal cancer. Over the years, that's gradually increased, and it was up to 59% in 2010. But when you look at people at the middle graph who have less than a high school education, there's a significant drop off. In 2010, it was only 44%. And that drops even further when you look at folks that are not insured. Now, with the ACA coming on board and Medicaid expansion, more and more people have insurance. So we're seeing more folks getting screened. At the same time, though, there is still a sizable population out there of folks that either don't qualify for Medicaid or can't afford insurance through the exchanges. And so they're still uninsured. And so there's still a group that are not being screened at the rates that they should be. Next. When we look at state data, and this is just data through federally qualified health centers, which are the group that I work with. In 2014, the nationwide average was 38.3% of eligible adults were screened. Here in Michigan, we were only at 30%. Now, the upside of this is that we've been increasing that number. Here in Michigan, in 2015, that number percentage jumped up to 37%. 2016, it was 40%. And in 2017, we were up to 44%. So we are making gains. And those are directly tied to a couple things. One is that, in 2014 is when we started our 80 by 2018 initiative, looking to getting that screening rate up to 80% nationwide. That's also when the primary care team, which I work with, started. And we've been focusing on getting the screening rate increased in the FQHC population. Next. Questions of where this data comes from. This is a lot of places you can get data. So if you're interested in digging further into this, there's the state cancer profiles.cancer.gov. That's a federal website that has a lot of great data. There's countywide data through the Robert Wood Johnson Foundation. There's some city data through Robert Wood Johnson. Of course, our website, cancer.org, is a great place to look. And the Michigan Cancer Consortium, michigancancer.org, has some great data. So there's a lot of places you can find more information about the incident rate of colorectal cancer in your communities. Next slide. And with this, I'm going to turn it over to Mike.
Thanks, Dave. That's fantastic information. Appreciate it a great deal. As Jen mentioned, her and I are both health systems managers. And what we do is we work with accredited health systems across the state of Michigan and basically help them improve their quality of care for patients and their procedures. And we also work with them in their accreditation process and a number of other events throughout the course of the year. Territory that I cover is basically the the western half of the Lower Peninsula. And so it's a wide territory, and I'm fortunate to work with some great health systems. So Dave mentioned screening a lot, which is huge. And why do we focus on screening? Well, a lot of it's just common sense. Preventing prevention and early detection of cancers save lives. Insurers are making it a priority. The earlier a patient can get screened, the less it costs the health insurance company in the long run to treat them. The CMS is making it a priority. CMS is an acronym for the Centers of Medicare and Medicaid Services. It's less expensive and less intrusive to treat early than late. And as Dave mentioned the Affordable Care Act earlier, the ACA, it covers most preventative screenings, such as a colonoscopy or sigmoidoscopy. Clinicians really do want to do what's best for their patients. A lot of times people think doctors order tests just to order tests and make some money, when in actuality, they really do want to, do what's right for their patients and make sure they're treated properly and successfully. It also meets quality goals and satisfies something called the PCMH, which is an acronym for Patient-Centered Medical Home. This is a comprehensive care team of a number of providers, whether it's primary care providers or oncologists. It's a team effort. It's based toward the whole person and centered on the patient. Next slide, please, Jen. And early detection means better survival rates. As we can see here, people who are diagnosed early with colorectal cancer, which would be like cancers contained to the entirety of the origin of the organ. If you see the number, it says 90 in local. That's a 5-year survival rate, and people get it early. And as you get farther down, they're diagnosed later. They're getting screened later. If you look at the distant number of 12%, this is a situation where the malignant cancer is spread to parts of the body through other organs. And just another point to prove why early detection saves lives. Next slide, please. There's a number of reasons why patients aren't getting screened. There's lack of awareness of colorectal cancer as a personal health threat. It's not something, people like to talk about. It's not something that people think is going to happen to them. There's a lack of knowledge about screening benefits. And that's one of the things that, has changed over time and with our E by 18 initiative. It does take time. It takes time to get screened. If you're doing a colonoscopy, there's a day involved. In many cases, there's a cost involved depending on your insurance. Not everyone has access to screenings. And some of that has to do with structural issues in health systems that people may be working with. Next slide, please, Jen. The biggest reason patients aren't getting screened is that their doctor never talked to them about it. And this is something that, your American Cancer Society is really working on, especially with primary care physicians and FQHCs, to get the word out to people to get their tests done. Next slide, please. Okay, and although the majority of primary care physicians do recommend screening, but they don't always recommend it to all at-risk patients, because there are demands on medical practices. It's patient-driven. Practice demands are numerous and diverse. As primary care physicians get more patients, they have more issues to deal with. And not all practices have the mechanisms to assure that every eligible patient gets the appropriate recommendation for screening. The more patients they get, there's a lack of navigation involved, getting patients steered in the right direction of where they need to go in their personal health care. Next slide, please. Now, there's a couple different ways that screening are done, and there's different types of tests for colorectal cancer screening. There are tests that can find both polyps, which Dave talked about earlier, and cancer. And then there are tests that just find cancer, and we'll look at both of those. Jen? So the tests that can find both polyps and cancer. There's a flexible sigmoidoscopy, a colonoscopy, a double contrast barium enema, and a CT colonography, also known as a virtual colonoscopy. Now, what these tests do is they look inside your colon and they look for abnormal areas. They're done with a lighted scope, and they also, use special x-rays. If there are polyps found, they can be removed before they turn into cancer. So boom, This is cancer prevention. And these tests are actually preferred if they're available and if a person is willing to have them. Next slide, please. The tests that find mainly cancer are as follows. The GFOBT, that's the fecal occult blood test, fecal immunochemical test, or FIT, or a stool DNA test, which is also referred to in many cases as Colorectal. All these test the stool for hidden blood or other changes in the system that might be signs of cancer. They're less invasive, easy to do. You can do them at home. They are less likely to find polyps. And if the results are abnormal, colonoscopy will be necessary. Next slide, please. Now, as Dave mentioned, we changed our guidelines. They were at 50 years old. Now they're at 45 is when we recommend people get the previously mentioned tests. Again, the tests to find polyps and cancer, we recommend that starting at age 45, you do one of the following. You get a flexible sigmoidoscopy every 5 years, or a colonoscopy every 10, or the barium enema every 5, or the virtual colonoscopy every 5. With the other tests that directly find cancer, we recommend that you do the occult blood test every year, or the FIT test every year, or Cologuard every 3 years. Again, we really want to emphasize if any stool test is positive, a colonoscopy should be done. Now, the United States Preventive Services Task Force, they're an organization that has their recommendation still at 50 years old for screening, and this is what health insurers go by. So even though we say 45 years old, the USPSTF says 50. Insurers don't have to pay for it at 45. However, we have found that if you have done one of the tests in the lower section there that primarily find cancer and the colonoscopy should be done, we believe that most insurance companies will pay for it, but you still should talk with your provider and with your insurance company to make sure. Okay. Next slide, please, Jen. And we'll turn it over to you.
So thank you, Dave, or thank you, Mike. I appreciate it. I'm going to talk a little bit about the ACS role in increasing colorectal cancer screening. And hopefully you have seen the newest tagline, 80% in every community. That's our goal and our objective is really to screen 80% in every community. Men, women, of different ethnic background, different nationality. That's our goal, 80%. This right here is the website on this slide for the National Colorectal Roundtable. The National Colorectal Roundtable is a clearinghouse actually for a coalition of public, private, and voluntary health organizations. And it's really co-funded between the American Cancer Society and the CDC. And it has a collaborative partnership of over 100 members, not only nationally, but decision makers around colorectal cancer. They work year-round on various tasks and task groups, and they have special topic meetings that are all covering colorectal cancer screening, communication, looking at the health agencies, looking at the medical professional organizations, and how the screening objectives can be managed or held. There's also another annual meeting that addresses all these topics and talk about the progress that we're making throughout the year, as well as some of the priorities around colorectal cancer. So my goal is to share with you what is happening in Michigan. Just to give you a little bit of background, we broke this up by the Southeast Michigan area, the Northern Michigan area, as well as the West Side. And so I just want to share a couple things so that you feel comfortable when you're in the community talking about what we are doing with colorectal cancer. And so to give some background, I wanted to share that we have FIT kits added for distribution on the Ascension Mobile Mammography Unit. We started that in 2008. Ascension is a collaboration between St. John and Providence Hospitals. We have a Southeast CRAN group, which is in the Metro Detroit area, that was recognized as a Spirit of Collaboration Honorable Mention at the Michigan Cancer Consortium. And we have a HEPA FIT project with Monroe and ProMedica Health System, and a ProMedica Health System and FQHC called Family Medicine in Monroe, providing free FIT kits as well as an opportunity for the community to get more information. We also have been involved in the MIU, which is the Michigan Institute of Urology, their health events. We've done this collaboration with Beaumont and Henry Ford since 2017, where men over the age of 45 can get fit tests from Beaumont and Henry Ford in collaboration with the American Cancer Society. We have a great Fit Kit partnership between Sparrow and Ingham County Health Department. And we also introduced a social media campaign called Polyps Not Politics. And so that was actually launched last November during the political time frame. And our goal was to get people talking about polyps at the Thanksgiving dinner atmosphere instead of politics. And so it was a fun tagline that we were able to create and make it get people talking about colorectal screening. Another example is, excuse me, the CRC screening with KCI at McLaren Flint, as well as the Fit Kit distribution within Bronson Battle Creek and the 5 Cs. For the Upper Peninsula, there's a lot of great activity happening within the Bay Tribe Change Grant for CRC. So there was a grant that was provided to the Kinawa Bay Tribe. There is an Upper Great Lakes HCCRC and an HPV initiative. Sault Ste. Marie Tribe also has some activity going on with colorectal cancer. The Bay Mills Tribe is connected to CRC, but also HPV. And the Intertribal Council provides with the Three Fires grant for around colorectal cancer. In the Lower Peninsula, Thunder Bay Healthcare Center is actually working on some CRC and HPV information. Elkona Healthcare is working on CRC. Saginaw Chippewa Tribe, Little Traverse Band, Northwest Michigan Health Services is also working on colorectal cancer and HPV activity with the American Cancer Society. And finally, the Honor Community Health Center is a quality improvement project to increase colorectal cancer screening. Covenant Community Care, which has offered the Grabada Foundation grant to increase colorectal cancer screening, and CHAS will be starting a QI project to increase colorectal screening coming up. Again, with the Lower Peninsula, Washtenaw County Flu Fit partnership between the University of Michigan and the Washtenaw County Health Department, and then the Michigan Primary Care Association Colorectal Cancer Workshop in May is helping provide more information to FQHCs around colorectal cancer screening through QI and evidence-based interventions. This is a quote here that we received from Josh Kellums, an ACS primary care partner of ours. He says, "I think the thing for me to highlight would just be our experience around improving screening rates. I encourage anyone working with organizations, small or large, employers, and corporations to listen for the need or desire for their employees or special populations to better access screening. If that's the case, my team can work with them to implement evidence-based strategies that can be tracked and measured to increase screening utilization rates." So we really appreciate Josh making this comment and this quote for us, just to kind of tag it all together and bring it all together. You will see that I have a call to action, but I want to acknowledge that there are 2 other slides that were not in this deck for some reason. And we do have a call to action for Mike's presentation, and we have a call to action for Dave's presentation. And so we will make sure that you get an updated slide set so that you can present it to your community and the volunteers that you're working with. For my call to action, I'm asking you to be an 80% in every community, staff or volunteer ambassador, share the resources and information you have learned in the community, help increase the awareness of colorectal screening by reminding people you come in contact with that the screening age begins at 45, utilize cancer.org and your health system and primary care staff as a resource, and share the accomplishments that are happening across the state. Now, as for Dave's call to action, I do want to comment that his call to action is making sure you remind yourself that colorectal cancer is the 3rd leading cause of cancer death in men and women combined, and colorectal cancer is a cancer prevention, and we want you to follow the ACS guidelines. And when Mike spoke, he wanted you to share the points of there are options for colorectal cancer screening. Know what your family history is and understand the alternative guidelines. Also know that ACS changed the guidelines, so make sure you follow them and look at any abnormal results. It's really important that you take away these 3 points from Dave, Mike, and I, and share them with the community that you're working in. At this time, we are done with the presentation unless there are any questions. We can open it up for any questions if you have any. If you don't, we will end the presentation and we'll make sure that the slide deck gets updated and sent out to you, as well as making sure that you get the recording to share with your volunteers. So I'll ask if there's any questions. Feel free to come off mute and ask, or we can close it. Okay. So I think we don't have any questions, but please know that Dave and Mike and I are a resource for you around colorectal cancer, and any primary care physician as well as health system manager is it's a resource for you as well. And most definitely the cancer.org website and 1-800-227-2345 can access information for you and your community. Thank you very much.
Great job, guys.
Thank you.
Thank you.
All right, looks like we're the only three still on.